This conference will now be recorded.
So welcome everyone to today's webinar, which is being hosted by the FES and Technology Task Force of the SCI Special Interest Group. My name is Kristen Musselman and I will be moderating today's webinar. I'm a scientist at the Toronto Rehab Institute and assistant professor in the Department of Physical Therapy at the University of Toronto. Before we get started, I just have a few housekeeping details to review with you. First, if you could please put your phones and computers on mute, that would be appreciated. We will also have a question and answer period, but we're going to wait until the end of the talk to have that questions taken. And then lastly, just a reminder, today's session is being recorded. So it is my pleasure to be able to introduce today's speaker. Dr. Ashraf Gorgey is currently the director of the Spinal Cord Injury Research at Hunter Holmes McGuire at VA Medical Center, and he's also an associate professor in the Department of Physical Medicine and Rehabilitation at Virginia Commonwealth University. He has a bachelor and master's degrees in physical therapy. He acquired his PhD in exercise physiology in 2005 with a special emphasis on electrical stimulation, muscle activation, and fatigue from the University of Georgia. He completed a postdoctoral fellowship at the University of Michigan with a special focus on studying the adaptations in body composition and metabolic profiles after spinal cord injury. His research background is in rehabilitation and exercise physiology with a special interest in individuals living with spinal cord injury. His research work has focused on investigating rehab strategies that could improve the quality of life of individuals with spinal cord injury and also minimize the health-related secondary complications of spinal cord injury. His research has received the national recognition of different organizations such as the Department of Veteran Affairs and the Department of Defense. And he has published close to 100 peer-reviewed articles and presented nationally as well as internationally. And so we're very pleased that he's able to share some of his work with us today. Please go ahead, Dr. Gorgey.
Okay, well, thank you so much and for giving me such opportunity. And also I want to acknowledge the FES task force, Kristen Muslim from Rehab Institute of Toronto also co-chairs the FES task force with me. And it is an opportunity to introduce the task force and its effort to bridge the gap between research and clinical field. We realize that's almost like 17 years gap between research and clinical field, and that's why we would like to establish a platform for clinicians to come and learn about what's going on in the field of research, and they don't have to wait for years for publication to come through or accepted for you to be able to access this research knowledge. Also, it is also serve as a platform for researchers from all over the world to come together, share ideas and share interests, and maybe establish collaboration. So that's our FES task force, and it is not only the FES task force at this point, it is the FES and technology task force, because coming up sessions or series of webinar will be about other technology very similar to exoskeleton and the strides that made in the field with exoskeleton rehab. And the other topics that we would like to highlight on would be brain-computer interface. So these two topics are by far will be our next webinars, and we'll highlight on as we move on. My emails are attached if you're interested to email me later if we don't have time to talk about different things, but hopefully you can reach out to me at any time and I'll be more than happy to address any questions or concerns that you have. This is the topic of my presentation. That is electrical stimulation from exercise locomotion. I felt like it is our responsibility just to share with you the knowledge that we had or we had at this point, and the progress that made, and how electrical stimulation comes that far to becomes a very important for persons with spinal cord injury, and how this strides facilitates people who never had a hope to regain recovery or stand up and walk to becomes a dream for many of patients with a spinal cord injury or individuals with spinal cord injury to be back on their feet and restore locomotion. This is disclosure statement, and like I mentioned, I'm the chair of the FES task force, and also I'm funded from the Department of Defense as well as Department of Veteran Affairs. So just to make the story simple, I'm going to structure the presentation into three major topics. The first one is to share our current knowledge about electrical stimulation and how electrical stimulation can facilitate restoration of muscle size in spinal cord injury, how we can build up muscles, why it is important to build up muscles, what is the limitations on application of FES, and how can our research knowledge can help us to improve the efficiency or applications of FES. That's the first topic. The second topic, which will be very important, for years there is a group of patients with a spinal cord injury who cannot benefit from applications of electrical stimulation. At this point, this observation or this problem is no longer exist. We and others group in Europe have introduced new technology. It's called the long pulse width stimulation. It's a very effective technique to stimulate denervated muscle. It can be used for other conditions, but right now we're going to talk about people who have denervation below T10 level of injury, where their coda equina has been injured, or the nerve roots that's coming from the lower part of the cord has been injured, and before they cannot benefit from technology of electrical stimulation, and now we can activate their muscles, and we can eventually or hopefully will be able to restore muscle size again. And then finally, we're going to talk about the breakthrough in science, or scientific breakthrough that comes very close to like fiction movies, where people have started to use transspinal stimulation, and what is the scientific evidence about using transspinal stimulation, epidural stimulation, to help people to regain some of the functional movement below the level of injury, and eventually stepping and helping them to restore locomotion. So I'm going to start here by our basic knowledge about stimulation parameters. This is a very important topic, and for years we invested the time and effort to try to clarify this. So if you look at the on the part of the panel on the left side of the panel, you can see here what we call it muscle mapping, and this technique has been used since early 90s, where it activates the muscle. And you immediately capture resting images of the muscle, which means without activation. And then after you finish the activation with electrical stimulation, you take someone back to the magnet, you will be able to see the difference in signal intensity between the muscle has been activated and the muscle that has not been activated. And based on this, you can tell exactly how much muscle tissue was able to activate. This was very effective because helps people to understand how is the current spread into the muscles, and unlike EMG activity where you can just get electrical activity, that can just like you can draw or delineate the anatomical activation of the muscle. Where exactly have you activated the muscle? So we have done this study back in 2003 during my PhD program, where we put electrical stimulation during isometric contraction, and we introduced 3 different protocols. One protocol aiming to change the pulse duration, one protocol aiming to change frequency, and one protocol aiming to change the amplitude of current. So we're starting here with the pulse duration. So when we introduce one protocol that's basically stimulating the knee extensor at 450 microsecond, and another protocol stimulating the knee extensor at 150 microsecond, and in both protocols the frequency was similar and the amplitude of the current was similar. We basically found that a longer pulse duration able to generate about 55% more torque. So this is our first observation, that with longer pulse duration, close to 500, which is in this case 450 microsecond, you can generate more force or more torque inside the knee extensor during isometric contraction. When you look at the mapping of the muscle, you can see the same exact protocol result in more activation of the knee extensor. So the knee extensors here are able to generate more, about 40% activation in the knee extensor compared to the shorter pulse duration, which is 150 microseconds. So this is for pulse duration. When we look at the amplitude of the current, we introduced two protocol. One protocol generated force close to 75% of someone maximum voluntary contraction, and another protocol close to 45% of maximum voluntary contraction. The reason we picked 45 at this point, because this is what most people used in clinic and in research, whereas 50% is more tolerable by the majority of patients, and 45% has been shown to increase the strength of knee extensors. So we went a little bit higher, which was 75%. And we indeed showed that when you introduce the 75%, you would be able to generate at least 30% more force inside the knee extensor, and you will be able to activate 30% more knee extensor. So now we have two observations: the pulse duration and amplitude of the current works to increase both the force and the amount of tissue activated of the knee extensor muscle. When we did the same observation for the frequency, and the way we did the frequency, we introduced two different parameters. One is 100 hertz, and another one is 25 hertz. And we did the same test. We measured torque and or force and muscle activation. We found that compared to the 100 hertz and 25 hertz, we were able to generate more 25% increase in force, but when we look at activation, there was no difference. So we learned a very important thing about this, that's both amplitude and pulse duration helps to increase force and activation, whereas frequency only increase force but not activation. Frequency can increase force by the release of calciums, or by how much calcium can be released from sarcoplasmic reticulum, and that's why we picked 100 hertz and 25 hertz. We moved on. I don't know what happened to my screen. I cannot move to the next. Okay, so we moved on to another study, and this study was in 2013 in the spinal cord specifically, and we found that when we are introducing a special amount of current, let's say 100 milliamp, we found that people can respond good to the 100 milliamp. Other people do need more current than 100 milliamp, and we didn't understand why this is the case. Why would someone, if you put up electrodes in his legs on knee extensor, turn up the current to 100 milliamp, they can straighten up their leg without having any problem? And we felt that maybe it could be the subcutaneous adipose tissue, so we decided to look more closely to their MRI. We found, and we classified the group into responders and high responders, or low responders and high responders, and we found that the groups that have less tendency to generate leg extension or to move leg extension, and we did this over three times, so you can make sure that we see the same observation. And we indeed, as you can see in the upper panel, we were able to detect the same observation in 3 different days or 3 different times, and that the people were able to move exactly once you introduce a specific amount of current. If you look at the lower pattern here, you can see the difference, representative MRI images between a person who is a responder and a person who is low responder, who needs more current to move his leg. You can see the responders have less subcutaneous adipose tissue, have more muscle cross-section area, and less intramuscular fat. And you can see here that's on the right side of the panel, that there is more intramuscular fat, which is fat infiltrated inside the muscles after a severe atrophic changes. Surprisingly, someone may say, oh, maybe this is a high level and this person is low level of injury, this is high level of injury. Most of them were matched based on their level of injury. So both of them have the very similar or very close level of injury, but you can see the injury in one person was dramatically impacted muscle health and result in infiltration of intramuscular fat. And you can see this is the results on this side here. You can see that the people who are responders tend to have more muscle to adipose tissue ratio, and as well less intramuscular fat compared to less intramuscular fat over here compared to the low responders. So this is all of this is accumulated significant knowledge. All of this has just studying the first study that's providing us with information about how we set up the parameters and what is the appropriate parameters that we can use for increasing force and muscle activation and eventually reduce fatigue, what it changes in the muscle quality that happen after a spinal cord injury, and put them at indeed that's in order to restore those muscles, we have to apply the appropriate stimulation parameters in order to get them in order to restore muscle size. So we start our first study, and this is this study has been done at Indiana University, where we have folks with a spinal cord injury randomized into two groups. One group received resistance training plus dietary consultation, and the other group received only dietary feedback. And we set them at standard American diet, where you can eat 45% carbohydrate, 30% fat, and 25% protein. And we did 12 weeks, twice weekly resistance training. And the way we set up our resistance training protocol, where we apply electrodes on their knee extensor muscles. One electrode is placed on the vastus lateralis, and another electrode is placed down close to the knee joint on the vastus medialis. And this way we can have the current spread in a diagonal way and activate most of the knee extensor. And this is very important. On the top of this, we used a commercially available ankle weights that you can cheaply buy them, and we can train the person where they can activate the legs or activate the knee extensors muscles. And the way we do it, we stimulate the right leg first, then 10 times, and then move to the left leg, and then come back to the right leg, and we do 40 times on each leg, and this would be one time, and we do this twice a week for 12 weeks. Excuse me. Here is some of our results. You can see that that's for the whole thigh. This is whole thigh means entire muscles of the leg, entire MRI muscles of the leg, no bone cross-section area or no subcutaneous adipose tissue cross-section area. We found increase in the entire thigh, 28% in the groups that did the resistance training with dietary feedback, whereas the group that did only the dietary feedback, there was no changes in their whole thigh muscle cross-section area. Over here, when you look at the knee extensor itself, which is rectus femoris and 3 vasti, you can see that the group that did the training over here have 35% increase in muscle size. And this is in complete persons with a spinal cord injury as well, using magnetic resonance imaging. Whereas over here, you can see that the group that did the diet, not only found increase in whole thigh muscle cross-section area and knee extensor, but we have demonstrating increase in the knee flexor muscle, although by 16%. Although the knee flexor muscles really didn't get any electrical stimulation, but we feel like maybe it was bleeding of the current to the knee flexors that result in activation of the knee flexor, or maybe some growth factor release from the trained muscles that impact the neighboring muscles. The improvement also comes with metabolic improvement, which was big deal for us. If you look here on this side of the panel, this is as a result of oral glucose tolerance test. This is the glucose area under the curve before training and glucose area under the curve after training, and this is both groups. And you can literally see that there was no changes between baseline and post-intervention, and baseline post-intervention in both groups. Maybe it looks lower, but there is no change. But the surprising thing that when we looked at the insulin signal, you can see that the groups that did the 12 weeks of training twice weekly, you can see that the amount of insulin or how much insulin you need in order to dispose of the glucose has significantly decreased in the groups that did the 12 weeks training. And this is very important thing, because we know that persons with spinal cord injury usually accompanied with dramatic insulin resistance as well as glucose intolerance. So the fact that you can build up the muscles and you need less insulin to dispose the same amount of glucose, this is a very important finding. This means that training was able to convert someone from being metabolically inflexible to metabolically flexible, or convert the muscle in person with a spinal cord from being metabolically inflexible, which is more fast glycolytic type with less number of mitochondria, to become fast oxidative glycolytic and be able to dispose this glucose. And this is also accompanied with decrease of percentage intramuscular fat. Because we know that our population suffer also a dramatic drop in their testosterone and serum testosterone level, 43%. That's the prevalence of how many persons with spinal cord injury have what we call hypogonadism, which is characterized by testosterone level below 300 nanogram per deciliter. We realize that having or administering testosterone replacement therapy in transdermal way, this can help increase the testosterone level and help us improve the efficiency of our resistance training. So we did the 16 weeks randomized clinical trial that was just recently published in Journal of Neurotrauma. And basically we randomized group into 11 persons received twice weekly of resistance training and testosterone replacement therapy, and the other group received only testosterone replacement therapy. Over the 16 weeks, we were able to progress ankle weights. As you see here in this slide, you can see this person's here early in the training where he's only carrying 8 pounds only. Over here towards the end of the training, he's closing 2 layers of weight on his legs and close to 24 pounds. The average progressive weights across the 16 weeks in the entire SCI population was close to 20 pounds. And this is a big deal, that you can take someone who's completely paralyzed and you will be able to train him so his knee extensor muscles can come close to lift 24 pounds. That's a significant amount of weight. I encourage you that you can just try to lift it on your biceps, and you see how much weight is this. You will sense that there is a significant amount of weight on paralyzed muscle. So what is the result? And this is just like a snapshot of the important result, and as measured by MRI. And again, we are only talking about persons with complete injury, complete spinal cord injury. You can see here we divided our results into 3 layers: whole thigh cross section area, which means thigh adipose tissues, thigh subcutaneous adipose tissue, muscle cross section, bone cross section, everything's under the MRI, so the entire circumference from outside. So this is the area, and you can see on the blue one is testosterone resistance training group, and the gray is testosterone only group. You can see this is the right leg. You can see there's almost increase in the thigh circumference, thigh cross section area by 20 centimeters square. When we move to the second layer, which is only the whole entire muscle of the thigh with no bone, this time no bone, no subcutaneous adipose tissue, just pure muscle, you can see that both the right and left leg show the same pattern, whereas the testosterone only didn't increase much. The right and left leg in our population increased by 20 centimeters square. This is an absolute increase in the cross-section area. When we look at the absolute muscle cross-section area, this means that there is no subcutaneous adipose tissue, no bone cross-section area, no intramuscular fat, just the pure muscle. And you can see that there is also increase by 20 centimeter area. That's for area as well. Because we usually sometimes get criticized that people after training, what will happen to this population after we finish training, and once you stop the training, everything will reverse back or go back to its original point. We ended up developing a program through our telehealth system where we can get our folks to be trained using FES or neuromuscular electrical stimulation at home while we are using our telehealth system. The telehealth system here is just very similar to our previous electrical stimulation unit, but in this time it is just portable e-stim unit with battery operated, and we provide them with ankle weights, and we measure MRI also before and after for 8 weeks, and you can see here some of our results that we were able to see. Despite the short period of intervention, we have one leg trained and the other leg served in the same control. This way we have to minimize how many patients has to be included in the study, because one leg in the same patient is being the training limb and the other one is serving as his own control. And we showed that on the training muscles, on the training limb, we're able to demonstrate here that for the knee extensor, compared to baseline and compared to the untrained limb, there is almost like 20% increase in muscle size. And also this increase in muscle size is accompanied by reduction intramuscular fat in the whole thigh, as well as a significant reduction of intramuscular fat in the knee extensor. This was very important finding, because now we can not only train people at the lab setting, but we can take patients and train them outside the lab using a telehealth system, which is very simple, and it is feasible approach anywhere. We have also have made it a significant work in regarding the use of FES cycling, lower extremity cycling, realizing that the limitation of neuromuscular electrical stimulation, where you only can train one limb, one muscle, we have been using functional electrical stimulation to stimulate multiple muscles, knee extensors, glute, leg muscle, in order to improve the overall metabolic health in person with spinal cord injury. We have really published a journal of video experimental research article that show step-by-step, as well as showing the videos and how we can activate and stimulate these muscles. I encourage all you, for the sake of the time, to access this article and have a look at the procedure and determine how we can activate these muscles. The biggest problem that we identify with FES is that the current guideline that's provided for FES cycling is all over the place. Everyone is doing his own thing. There is no established guideline. Also, we realize that only using FES, even if we turn the motor of the bike off, means that the person who are paralyzed do not get any sense. The metabolic cost of FES during cycling is very, very low, especially when you're dealing with person with tetraplegia, which means high level of injury compared to persons with paraplegia or even able body, if they have to do the same cycling protocol. So we have done a study in 2014 where we introduced different stimulation parameters, trying to activate the muscles, kind of like what we learned from our initial study in 2006, where we can activate the muscles at different pulse durations in order to see if we can increase the metabolic activity of the muscle by increasing the pulse or the pulse widths during electrical stimulation in persons with tetraplegia, because this are the most vulnerable population to metabolic dysfunction and metabolic disorder. And basically what we found that despite different pulse duration, we were unable to increase the metabolic activity. Maybe our VO2 system was not sensitive enough to capture changes in muscle activity and increase of energy expenditure. But surprisingly, on the same study, we found a very important finding. We ended up measuring torque and we're measuring fatigue, and this is, you can see it here on the right panel. And despite that, we introduced 3 different pulse duration. I'm just today presenting 2 of the pulse duration, the 200 and 500. When we measure the force frequency curve, and this is how much torque generated over a number of frequencies. We found that this is the force at baseline, the first blue line, the first greenish line, I'm sorry, and this is the blue line is how much force immediately happen, how much drop immediately happen after cycling. You can see it is the same pattern here, almost the same pattern at pulse duration of 500 microseconds. So basically, you put someone on the bike, you make him exercise, and before you get him on the bike, you measure the force frequency curve. And then once you finish the force frequency, once this person finished cycling, you bring him back and measure his force frequency curve using Biodex, and you can see that the force from baseline or from pre-cycling to immediately dropped almost like 40 to 50%. This is just well established. But the surprising thing is that if you bring this person back to the lab 2 or 3 days later, you will still find that the force, even despite whether you've done 200 microsecond or 500 microsecond, you can see the force is dropping by 22 to 20%. And this is a big deal, a drop in force by this much, that this can tell us that either the acute bout of exercise-induced muscle injury or can resulted in a significant reduction in force. And that's why our recommendation based on this work, especially in acute stage, when you train someone with chronic tetraplegia or chronic spinal cord injury in the acute stage, it is highly recommended that the sessions or FES training sessions needs to be spaced out enough to allow this muscle to recovery. Otherwise, you will end up in exercise-induced muscle injury. Another problem that we have found early on with FES, that's most of the training sessions early on rely on carbohydrate utilization and less rely on fat utilization, and maybe it could be function of decrement in mitochondrial health and maybe introducing the hypertrophy training prior to FES cycling may help us to improve this phenomenon. But you can see here, this is just a whole body utilization. You can see the person who's exercising using FES cycling consume more carbohydrate or more sugar, whereas their fat utilization during the same exercise protocol is very diminished. And part of it also due to dysfunction in autonomic nervous system. Another study that has been done by Griffin, which is promising for FES, that showed that that persons who following 10 weeks of training, there is improvement of metabolic flexibility as measuring by plasma glucose in response to oral glucose tolerances, as well as the insulin. You can see that compared to the baseline over a number of time points up to 3 hours, there is enhancement of glucose disposal, very similar to what we have shown after 12 weeks of training using resistance training. Not only this, but the study showed improvement on some of the inflammatory biomarkers which can impede the metabolic signaling and metabolic health in spinal cord injury, as measured by C-reactive protein, interleukin-6, and TNF-alpha. The authors were able to demonstrate improvement at least 2 out of the 3 health parameters in a spinal cord injury. While we are doing one of our studies, 16-week testosterone and resistance training study, like I mentioned earlier, we ended up having 40 persons who were qualified, but out of these 40 persons, 8 persons, when they come to the lab to examine their response to electrical stimulation, 8 persons were not qualified. If you did the mass and ratio, this 8 person from the 40 is almost like 20 to 25% approximately. So 25% cannot respond to electrical stimulation, and this is part of it, as I mentioned earlier in my introduction, as part to injury of the coda equina or to the nerve roots that's emerged out from the spinal cord injury, makes this connection between the cord and between the paralyzed muscle, and that when you try to trigger this by electrical stimulation is not working. Made us wondering to what can we do to help these people, And this is just an MRI, pure MRI from our research group, showing how much impact happened to the muscle following denervation. Most of them are a spinal cord injury. One of them is below T10 and another person is above T10. And you can see here that despite this guy has a spinal cord injury, his muscle integrity, muscle structure, less intramuscular fat are still intact. This is a chronic person with a spinal cord injury, but despite this fact, this muscle is still in a good shape. Could be very likely to having muscle tone or spasticity that maintain muscle integrity. Whereas when we look here, you can see the person who have denervation or injury to their coda equina, their muscles are completely or almost gone. There is no muscle tissue left, fibrotic tissue, a lot of intramuscular fat. Basically, all the anatomical boundaries, anatomical landmarks have disappeared. And you can see if you look at the strength duration curve for the both groups, you can see that the strength duration curve here, that persons who have intact muscle, even if he's still spinal cord injury, needs less energy, which means the product of the pulse duration and the amplitude. Whereas over here on the left panel, this is for the denervated muscle. You can see the person who have denervation needs a lot of energy in order to get the muscle activation, and part of it because the disconnection or disruption in the nerve connections that going into the muscle. A group in Europe has introduced this, in Austria specifically, have introduced this technique using established protocols that have been used for years in animal model, and it's called long pulse width stimulation, where instead of having direct current, you introduce a long pulse duration in an interrupted way or in an interval way, and the pulse duration can start it up all the way from 300 milliseconds, not microsecond, 300 milliseconds, and can go down all the way to 150 milliseconds in order to activate the muscles in the denervated person with a spinal cord injury. So right now, the Dento-X is not FDA approved for clinical use, but it is approved only based on is based for research use. So we were able to capture this only for research application. The VA get excited, Department of Veteran Affairs get excited about this possibility and to activate the denervated muscles. We get training on how to apply it using very large gel type electrodes and covered with a sponge here, and the electrodes have to be very adherent to the person's leg, and that's why we wrap the electrodes around the knee extensor to make sure that the muscles activated correctly without causing the fear of damage or burn or skin problems is huge with this type of stimulation, especially as you don't have any sensation. We have started our first study here in Richmond, and now we have 2 participants. Both of them are going fine. One of them is very close to 6 months finishing. The other one just started 3 weeks in the study. No side effects, no complication whatsoever, and we are very excited about this because we can see in our first participant only in 6 months of training twice weekly that he has no response before as determined by electrodiagnostic, as determined by other things. That's basically you can see that his muscles will start to show some response and it is getting bigger in size. This is some of the scientific backgrounds from Europe or from the RICE program that showed here what's the effect of training using this much pulse duration, 120 to 150. Their protocol has to train participants 5 days a week. Our protocol we do twice a week, and this is based on our earlier evidence that showed twice a week is enough to evoke muscle hypertrophy. Their protocol goes for 1 year. Our protocol goes also for 1 year, and you can see here as they started with patients in a completely fibrotic stages. In over 1 year period, you're able to convert this fibrotic tissue into active red muscle tissues, which is great, which we are hopeful to accomplish the same outcomes, especially for the knee extensor, considering it is represents almost like 51% of the entire thigh muscle. Speaking of the spinal cord itself and moving towards our third specific aim for today, you can see that spinal cord injury is a spinal cord, I'm sorry, as an organ connected to the central nerve or part of the central nervous system. Several things has been identified, including in the lumbar region or in the lumbar sacral region, the introduction of the central pattern generator as a center for locomotion, and if it gets activated correctly. Also, the fictive phenomena or the fictive locomotion phenomena, where in the absence of supraspinal control, you're introducing magnetic stimulation or electrical stimulation to this center or to this region, you can get automaticity of the spinal cord, and it can generate a stepping and with self-practice or task-specific practice, very similar to body weight supported treadmill training, you can get this center to generate an ideal control of locomotion, as in persons with incomplete spinal cord injury, as well persons with complete spinal cord. So the first study here from Reggie Edgerton laboratory, where they tries the transspinal stimulation. And basically, what they've done, and I'm going to explain this in the next slide, they put an external electrodes around T11, and then they basically try to have their person side lying, and they hang their legs here, and through application of a carrier frequency at 10 kilohertz to minimize the impedance or the resistance to the current with this much pulse duration. And varies from one person. They customize the pulse duration based on each person response, and frequency 5 to 40 hertz, and this is how much current they utilize in this protocol. So basically, the patient is side lying here, monitoring their blood pressure, and basically their legs hanging from the ceilings in gravity elimination position. When they put this at the T11, activate from outside the body T11, you can see they get some EMG response very close to the biceps femoris as well, both the left and right, which is allowing the patient to move their legs. When they amplify their signals by having the patients activated at T11, L1 at C5, you can see that the magnitude of the response has increased dramatically both at the right and the left knee, as demonstrated by increasing the EMG activity. And the patient was able to move their legs only when their current was on, based on the current stimulation, not based on the intention of the patient, which means that the current turned on, and you can start to see an oscillation or stepping like movement during the stimulation. If they turn off the stimulation, everything disappears. So this study was able to show that at multiple level of transspinal stimulation, which is something that's very interesting to share, you can get a step-like connectivity as a result of a stimulation of the lumbosacral segment or the central pattern generator. This is kind of like the neurophysiology behind it, and so this is basically where you put the electrodes here, T10, T11, T11, T12, TL12, T12, I'm sorry, L1, and this is correspond to different segments in the cord. And you can see here on this graph, on this side of the graph, that you can get activation to different muscle group, but each muscle group has its own amplitude of current that you need to tweak or you need to adjust in order to achieve this stimulation. So you can see, for example, that tibialis anterior may need a different current stimulation than the medial gastrocnemius or than the soleus, and each time you increase the current, you get a better response for different muscle groups. So each muscle group basically at different level can stimulate it at different stimulate. Over here a little bit of the stimulation and how this is a stimulation works through both stimulation of the afferent response and going into efferent response and the role of interneurons. I'm not going to get into this just for the sake of time, but this is just telling you that this is where you place the electrode and this is where the firing happening, and a big component of it is the sensory afferent response that coming into play in the interneuron and causing activation of the muscles. Another thing that's really lead to breakthrough in science and breakthrough in the research of spinal cord injury is the introduction of epidural stimulation. And the epidural stimulation is basically, it is a paddle, 16 channel paddle where that inserted into the lumbosacral segment between T11 to L1, L2. And these panels here, each part of the paddle correspond to specific muscle groups that can be tweaked at different stimulation parameters using a simple tablet that's connected to a stimulator that's implanted inside the body. And basically this stimulator basically trigger the activation of this 16 elements electrode array. And we have all witnessed the improvement on locomotion, either in the Louisville group or under Susie Harkema, or in Mayo Clinic under other group, as well in Swiss group with Gregory Curtin, that demonstrated the ability of using different parameters or different types of epidural stimulation. I'm going to say why I'm saying this in a second. And to improve locomotion and stepping for the first time. And when I say locomotion and stepping, I mean by overground locomotion, overground stepping. The epidural stimulation is based on a lot of animal research that has been done for years that showed that basically in rat models or cats from Reggie Edgerton laboratory, that you can elicit or enhance a step-like movement on a treadmill. The more freedom that you can provide to the body, the more trunk control you will be able to achieve, as well as in a stepping-like activity on the treadmill once you facilitate and provide the different afferent stimulation in. This could be sensory cueing, afferent stimulation that result in neuromodulation at the lumbosacral segment or central pattern generator, or through activation, direct activation by the epidural stimulation that result, or by both. And you can see that's on the top here, on the side here, that's not only you can do electrical stimulation, but you can do some time of pharmaceutical intervention that increase the excitability of the motor neurons or interneurons in these regions. The Swiss group have introduced a very important things about the epidural stimulation, and say that there is during epidural stimulation that there is this orthodromic or antidromic pattern of stimulation that happen as a result of stimulation of the afferent response or the afferent loop of the motor unit circuitry. And their approach is just like to decrease the collisions that may happen between signal and dampen the effect of signal that use alternating current versus the direct current. The other groups here in the United States didn't appear to have a problem using protocol with this phenomena, but I just thought that this is something that's of interest that we may need to be aware of. And this is just like some of the research that has been done by Swiss group showing that by using both surface EMG and needle EMG, that there is some damping effect to the EMG signal as a result of this collision that's happened in some of the subjects that receive epidural stimulation. How much of this is of impact on locomotion stepping, I believe it is still yet to be established and is not really clear. And this has been established through different muscle groups, not only simple muscle group, in different subjects who undergone or underwent the epidural stimulation. This is a study from the Gill et al. From the Mayo Clinic group, where basically they have shown nicely that's when they have one epidural leave versus dual epidural leave, that person can achieve independence 43 weeks after training Here in 4 weeks, you can see this person walking at 30% on the trade, 30% body weight support on the treadmill, whereas here, after introducing the interleaved or 2 epidural stimulation at 40 hertz, you can see that he required no body weight support, and when he walked over ground, the person was achieved stepping with minimal assistance over ground compared when he has a single epidural stimulation over here. I'm still thinking that this is, although it is a really scientific breakthrough, it helps a lot of our understanding of neurophysiology. It still will help and guide our future studies in how to activate or neuromodulate this central pattern generator, and hopefully eventually it lead to more research in this area, so we can be able to achieve automaticity of the spinal cord and stimulation of spinal cord injury persons to the ways that we can achieve both standing and stepping, as well improve several of their cardiovascular parameters. So here is what I was just referring to it. Again, that's compared to his week 16. Here is week 16, and here is week 43 from the same study. The introducing of interleaved epidural stimulation or combined stimulation of different paddles result to improvement of independence with little support here compared to earlier when they used one paddle, where they need significant support from the patient during overground ambulation. So this is the summary of conclusions. So we showed clearly that using neuromuscular electrical stimulation in a very effective twice weekly for 12 to 16 weeks result improvement in muscle size. This is accompanied with improvement in metabolic parameters, very similar to basal metabolic rate, or improvement in body composition, although I didn't show all this data today for the sake of time. Also, the introduction of long pulse width stimulation for the first time may facilitate the stimulation of the denervated muscle and the restoration of muscle size and metabolic capacity of the muscle. This is very important, especially for those who have denervation or T10 or coda equina lesion. Also, finally, trans-spinal epidural stimulation may have a promising outcome about generating or eliciting stepping-like movement, and maybe a very future or potential rehab approach to restoration of locomotion in persons with a spinal cord injury. This is an acknowledgement to our research team and their support to the work that we have been doing over the last 10 years. And thank you so much for giving me this opportunity. And I'm ready to get any questions from you. Thank you.
Thank you so much, Dr. Gorgey, for a really fantastic talk. So we do have some time left. That the floor is now open for questions. So feel free, you can type your question. I'm happy to relay it for you, or feel free to unmute your mic and ask your question. Dr. Gorgey, if you don't mind just waiting for a few minutes to see if any questions come in, that would be great.
Sure, no worries. I'm available.
Hello, Dr. Gorgey. This is Jean Zanka from Kessler Foundation. I have a question from. Hi, how are you? Thank you so much for that talk. Excellent. In interacting with people with spinal cord injury here on the clinical side, there's often a lot of interest in stimulation and when it will become part of clinical practice. Do you have any advice for how you would recommend that clinicians or others that have direct contact with people with SCI address the questions they may have about stimulation and how soon it might transition into clinical practice?
Well, I mean, in my experience, Jean, as a physical therapist and as a researcher, the earlier that you introduce the stimulation or neuromuscular electrical stimulation to person with a spinal cord injury, is a better outcome. If you wait so long, you would run into a number of issues like being highlighted in my presentation, including significant or remarkable muscle atrophy, as well as infiltration of ectopic adiposity or intramuscular fat that would lead to reduce the muscle quality. And once you get reduction in muscle quality, it becomes so difficult to restore it back, even with muscle hypertrophy. So the earlier that you start this in your clinical practice, or the earlier you introduce this, and I'm talking the earlier as early as 8 weeks post-injury, becomes cognizant and proactive as a therapist or as a clinician. That's while you may not witness this because you don't have access to MRI or magnetic resonance imaging, that the process of atrophy is going in no matter what you do. Just having the patient sit and wait for you to introduce this intervention may delay the outcomes that you may expect from this intervention.
Thank you very much.
It's Kristen, Dr. Gorgey. I have a question as we're waiting to see if any others come in.
Sure.
I'm just curious what units you use for your different applications, like what actual.
Yeah, that's a great question. So over the years, we have using a unit called TheraTouch 4.7, and the reason we are using a biphasic rectangular pulse. That's the type of electrical stimulation or parameters that we're using, and we found that this is a commercially available unit, and the reason we continue to use it because it is available for clinician. Right now, Chattanooga comes with a number of different stimulation units that can be effectively used also in the same way. But since our protocols have been developed over the years using the TheraTouch 4.7, we continue to use the TheraTouch. But I would just say that Chattanooga also provide some handy and easy access stimulator unit for muscle activation.
Great, thank you.
Sure.
So we probably have time for 1 or 2 more questions. If anybody would like to ask a question, feel free to speak up, or you can type in your question to the chat box. So there is a question from Valerie. How do patients get into the epidural stim trials? Is there anything you can comment there, Dr. Gorgey?
Well, I mean, we have not started an epidural stimulation trial in our facility yet. We are hopeful that this is something that can happen in the future, and that's why we are interested in just going through all the existing knowledge before we start the trial, because as I introduced, there is still, despite that people highlight the breakthrough, but from the scientific basis, there is a lot of discrepancy in stimulation protocols on what appropriate protocol should be used. And this is, I want to say, a serious business. Centers need to be well prepared to do this. I realize that in United States they are only is under the umbrella of research, is not get the FDA clearance to utilize epidural stimulation. So we just have to be careful. The only 2 centers that I'm aware of, I should say that exist, but only 3 centers that's having epidural stimulation trial, active ongoing trial, are Louisville, Kentucky, Mayo Clinic, and Minnesota. So how you introduce the patient to this, I think you just need to reach out to them and contact, but my understanding that they have a long waiting list of people waiting to get into these trials, and that's why we're hopeful by the next year or so that more centers will open up and becomes an accessible intervention either for research or eventually, I had to say clinical because it's not going to be for clinical for a while. But this is, hopefully I would have answered the question. Mm-hmm.
Yeah, just follow-up question to that. Then is clinicaltrials.gov a good place for people to watch for trials opening up?
Right. Right. Exactly. That's definitely, and we get so many patients, so many clinicians reach out to us through clinicaltrial.gov, and anything right now has to be registered. It becomes a must. Like here in the United States, that any research trial has to do with anything with human, it has to be linked or registered at clinicaltrial.gov. So indeed, this is an access way or easy way to access ongoing trials. For different clinical population. Yes.
Okay, great. We have another question from Jan. So what pulse width do you recommend that you would start with, and the frequency? So maybe some suggestions of how to start with parameters.
That's an excellent research question, and for years until we figured this answer took us a while. But I can tell you, if you are dealing with a spinal cord with an acute training level, which means that he never experienced electrical stimulation before. That's what I mean by word acute, not an acute injury, but his muscles has never been trained. My recommendation is to start with 350 microsecond pulse widths and 30 hertz as a frequency, and the current as much as he can tolerate. If he's a complete injury and the current is not an issue, then you may have to means not an issue because he does not feel it or she does not feel it, then you need to monitor for blood pressure closely, especially if he has an injury above T6. So the pulse duration is 350 microsecond and frequency 30 hertz to reduce the possibility of the muscles to get fatigued. And if he does not have an issue with sensation, then you would need to monitor for blood pressure very closely because you may run into issues like autonomic dysreflexia or something like this. That's why you need to monitor for blood pressure.
Great, thank you. So we are just after 1 o'clock, so I think we'll draw it to a close. But if anybody has further questions, Dr. Gorgey included his email address at the beginning of the slides, and I think it's okay for you to email him with any further questions. So thank you all for attending, and thanks for the great talk, Dr. Gorgey.
Thank you so much. Thank you so much.